Hello, welcome to Nursing with Professor B. My name is Bridget. I have a master's degree in nursing education. I'm also a family nurse practitioner. In today's video, I'm going to be providing you with an ACLS cheat sheet that is basically everything you need to know for the written portion of the exam. My 2020 ACLS cheat sheet video was seen over 40,000 times, and I helped thousands of people pass the ACLS test. Before we get started, make sure you hit the like button, make sure you subscribe, and make sure you turn on that notification bell. Let's go. This video is for educational purposes only. If you have a question about a medical condition, please consult a qualified healthcare professional. The content in this video strives for 100% accuracy, but errors may occur. First of all, I want to say I try to make this as accurate as possible and without mistakes, but I'm not perfect. I do make mistakes. If you do notice a mistake, then your feedback would be appreciated in the comments. You can leave a comment below and I will fix it for the next video. I'm going to skim over this slide. I did record a BLS video and I cover this more in depth, but if you're ACLS, you already know the majority of this. The first step, of course, is you find someone that's unresponsive. You're going to tap them on the shoulder and you're just like, hey, can you hear me? And then if they don't hear you, you would activate 911. You get an AED if it's available, or you have someone else get an AED. This is on the test that you're going to have to check for a pulse, that it should take at least 5 seconds, but no more than 10 seconds. That's on the test. Also, there's a test question on there about agonal gasping, and agonal gasping is not considered breathing. So if someone is doing agonal breaths, that is not considered breathing. That was on the test. You do need to know that the compression rate needs to be between 100 to 120 a minute, and that for adults, the compression depth needs to be at least 2 inches, but no more than 2.4 inches. Also in my BLS video, I talk about children and infants. So if you are interested in that video, then please check out that video. Always, this was also on the test. When you're providing CPR, you want to be providing quality compressions. You need to have full chest recoil in between compressions so that the heart can fill. You want to minimize interruptions in chest compressions. So once you start providing chest compressions, you want to keep going. And really the only time you should be stopping is when you're rotating. If no trauma is suspected, then you utilize the head tilt chin lift. If there's suspected trauma, you would do the jaw thrust maneuver because you don't want to potentially jeopardize their spine anymore. If it's a spinal cord injury, you don't want to make it worse. The compression to ventilation ratio is 30 compressions to 2 breaths during single rescuer or multiple rescuer. This is different for children and infants. Again, refer back to that video. Ventilations with an advanced airway, this will be also on the test. You want to ventilate the patient 1 time every 6 seconds for a total of 10 per minute if there's an advanced airway in place. Once again, that's 1 time every 6 seconds. I do believe that was also on the test. And you want to always look for visible rise of the chest. You want to avoid seeing the diaphragm raise because then it's not in the proper place. All right. Once an AED defibrillator is available, you want to use it immediately. And immediately upon defibrillation, start CPR beginning with chest compressions. So to reiterate, after you defibrillate, you don't stop, you don't check for a pulse again, you immediately, once the machine says shock delivered, right away, you're basically jumping on top of that person again to start chest compressions. High quality CPR will increase the chance of victim survival. We've gone through this, that you want to start compressions immediately, that it should not take more than 10 seconds to check for a pulse, that you are compressing at a rate of 100 to 120 per minute for all patients. And for adults, it's a depth of 2 inches, maximum of 2.4. Again, that was on the test. You want to allow for full chest recoil. This will ensure that the heart can adequately refill in between compressions. And you want to see visible rise of the chest in all patients. Avoid excessive ventilations as this can lead to decreased blood flow. You want to turn the AED on and you're going to follow the AED prompts. That's your first step. And I do believe that they asked that question during one of the simulations, what's the first step with the AED? The AED becomes available. You want to immediately use it. This is the only time that stopping CPR mid 2-minute cycle is appropriate. After this point, you will only use the AED on the 2-minute pause pulse check. If the AED analyzes and determines if the AED says shock advised, you're going to clear all bystanders and healthcare workers. So you're going to say all clear, and then if everybody's all clear, then you can do shock delivered. Again, immediately upon defibrillation, you're going to resume CPR, beginning with chest compressions. Remember CAB. I didn't say that in this video, but that's the order of CPR, is compressions, airway, breathing. Adult pads should be used on adult patients, and the AED can be used on a victim that was submerged in water. You want to first remove the victim from the water, and then you wipe down the victim's chest. The AED can experience difficulty if the victim's chest is hairy. So when possible, the victim's chest should be shaved with a medical razor. Most AEDs will bring a razor. And if there's no razor available and you have enough pads at your disposal, if it's an adult, you can use the pediatric pads to rip off some of the chest hair. Again, use common sense. If you only have one set of adult pads, that's not what you're going to use to wax the patient, right? Foreign body airway obstruction, choking victims. In a responsive choking adult, you're going to do abdominal thrusts until the item is dislodged. If the patient becomes unresponsive, you want to assist the victim to the floor. You carefully support their head, and then, of course, call 911 and start CPR, beginning with chest compressions. Once again, CAB, compression, airway, breathing. This is, again, a review. Remember that one of the first things you want to do before you go rescue someone is you want to ensure that the scene is safe prior to approaching. For example, what if there's a live wire, electricity, and water? You don't want to electrocute yourself. So always you want to ensure that the scene is safe. If the victim has no pulse and is not breathing, that's when CPR is required, specifically chest compressions. When assessing a pulse, again, you want to check to no longer than 10 seconds. You want to palpate on adults the carotid artery, on infants the brachial artery. So when performing chest compressions on an infant that's single rescuer, you want to do the 2-finger technique. When you're performing chest compressions on an infant, which is with 2 rescuers, then you do the 2-thumb encircling hands technique. Once again, if there's no suspected neck injury, you can do the head tilt chin lift. If there is suspected neck injury, you're going to do the jaw thrust maneuver. You want to make sure that you are providing a good seal. The rescuer should make the best to seal the patient's nose and mouth when providing breaths. So if no method is available for safely providing breaths, such as a bag mask device, a pocket mask, then hands-only CPR should be used at a rate of 100 to 120 compressions per minute. That may be on the test because the AHA wants you to be safe. Suctioning of a patient should be limited to less than 10 seconds. The oropharyngeal airway should be measured from the corner of the mouth to the angle of the mandible to ensure adequate size and placement. Do not provide excessive ventilations. It can cause gastric inflations. Remember that if you're providing good CPR, visible rise of the chest will be visible. If you're doing rescue breaths, adults should be ventilated once every 5 to 6 seconds. And with an advanced airway in place, compressions are constant with no pauses, and ventilations are provided once every 6 seconds for all patients. This is important. They ask this on the test also, that continuous waveform capnography is the preferred method for monitoring the placement of an endotracheal tube. They'll ask you something along the lines of, is it pH? Continuous waveform capnography is the correct choice. The PET CO2 is the partial pressure of end tidal carbon dioxide, and that should maintain above a reading of 10 during CPR. Sometimes that will be asked too. If the numerical reading decreases below 10, then it is assumed that chest compressions are not adequate. That sometimes will be on the test. Cardiac arrest team dynamic approach. The structure or universal approach to the cardiac arrest emergency does not change regardless of profession or setting, whether it's pre-hospital or in-hospital. You're still doing CPR, and it should take place in 2-minute increments, allowing for approximately 5 cycles of 30 compressions to 2 ventilations. And upon completion of a 2-minute CPR cycle, a pulse should be palpated, again, for at least 5, but no more than 10 seconds. If a pulse is felt, then post-cardiac care should be initiated. If no pulse is felt within 10 seconds, the rescuer should switch positions and compressions should be immediately repeated. If the patient requires defibrillation, CPR should be continued while the defibrillator charges as to minimize interruptions. When electricity arrives at a cardiac arrest incident, it is the only acceptable reason to stop CPR. So again, when the AED arrives, that's the only time to stop the CPR, and the defibrillator should be used immediately. Immediately upon the use of electricity or confirmation that electricity will not be used, CPR should be started beginning with chest compressions. So I have a song for shockable rhythms, and it goes something like this. D-fib for V-fib impulses V-tach. Don't defib asystole, you won't get them back. D-fib for V-fib impulses V-tach. Don't defib asystole, you won't get them back. So that's how I remember which rhythms are shockable. Pulseless, keyword is pulseless for V-tach, and V-fib. With defibrillation, biphasics is 120 to 200, up to 360. Monophasic is 360. Drug therapy, epinephrine is 1 milligram every 3 to 5 minutes. Amiodarone, the first dose would be 300, second dose would be 150. They like to ask these things in the simulations when they're like, let's say that your simulation is pulseless V-tach, then they'll have you defibrillate them, and then they'll have you go through the drug therapy. And they usually do ask something along the lines of like, how much would you give? What would be your first dose of amiodarone? What's your second dose? Someone in my video last year wrote that in the hospital setting that they are shocking occasionally PEA, and I think they told me even asystole. So remember, there's textbook world and there's real life world. I'm not here to judge other people. I'm here to teach you, right? So textbook world, we don't shock PEA or asystole, okay? The rationale this person gave me was, well, they're shocking it just in case it's very fine VFib. So I'm not here to judge. I'm just telling you for test purposes, you do not shock PEA or asystole, okay? You will not get that right on a test if you shock that, if you attempt to shock that. The rationale is you can't restart the heart if it's already in PEA or asystole. Now, what shocking the heart does when there is a rhythm is it basically resets it. Think of a computer that has been completely demolished. Like once it's broken, turning it off and on won't work. But if your computer's frozen and you turn it off and on, it does reset it and it starts working again. So for non-shockable rhythms, what you're going to do is epinephrine 1 milligram every 3 to 5 minutes. And you want to treat reversible causes of H's and T's. And all your H's are here. If you're listening to this, maybe in your car, I'll read this for you. Hypoxia, hypovolemia, hypothermia, hypokalemia, hyperkalemia, hydrogen ions, and then the T's are tension pneumothorax, toxins, tablets, cardiac tamponade. Known causes of your H's and T's will never supersede epinephrine administration. So you're giving epinephrine and then you would treat reversible causes. If there's ROSC or return of spontaneous circulation, so for example, if you see there's a return of a pulse, you immediately assess pulse, you ventilate appropriately, you begin a fluid bolus of normal saline to obtain a minimum BP of 90 systolic. In the ACLS book, it also says lactated ringers would be acceptable. You want to provide approximately 1 to 2 liters of normal saline. Dopamine is 5 to 10 micrograms per kilogram per minute for continued hypotension, or epinephrine 0.1 to 0.5 micrograms per kilogram per minute for continued hypotension. Patients who achieve ROSC should be transported to a coronary reperfusion capable facility, aka a cath lab. Okay, that's just a fancy way of saying send them to cath lab. And this is on the test. If it's a post-code STEMI, there's a 90-minute door to balloon time. So 90-minute door to balloon time for a post-code STEMI. Induced hypothermia, or code cool as some people call it, or targeted temperature management should be implemented in hospital with a target range of 32 to 36 degrees Celsius for at least 24 hours. Do not begin temperature management if the patient is conscious or answering questions appropriately. ACLS medical emergencies. Even though here we're going to get a little bit more in depth into ACLS, all the other stuff that came before is also on the test. So it is important that you know the other stuff and not just this. So for bradycardia, first degree, second degree, type 1, type 2, third degree block, assessment of patient is critical. And the thing is, you treat them if they're symptomatic. If a treatment of symptomatic bradycardia, okay? Atropine, 0.5 milligrams every 3 to 5 minutes. If atropine is ineffective, consider transcutaneous pacing. Consider dopamine, 2 to 20 micrograms per kilogram per minute, and consider epinephrine, 2 to 10 micrograms per minute. Supraventricular tachycardia, or SVT. First, you want to try vagal maneuvers, then adenosine 6 milligrams. You wait 1 to 2 minutes. If there's no conversion, you administer 12 milligrams. If SVT persists, seek expert consultation. If they're unstable, so here the keyword is unstable, you want to perform synchronized cardioversion. Okay, it has to be synchronized because if it's not synchronized, you're going to kill them. Ventricular tachycardia, VTAC with a pulse. So you do not defibrillate this because it has a pulse, right? Remember, defib for VFib and pulseless VTAC. So you don't defib VTAC with a pulse. So with a pulse, you're going to administer 150 milligrams of amiodarone over 10 minutes. If unstable, you perform synchronized cardioversion. Once again, synchronized, 100 to 200, 300, or 360. For atrial flutter, again, this shouldn't be on the ACLS, but here it is anyway. You're going to administer cardizem 0.25 milligrams per kilogram over 2 minutes. If they're unstable, you would perform synchronized cardioversion. This is a typo here, 50 to 100, 200, 300, and then 360. Acute coronary syndrome, indication of a possible STEMI. You immediately want to obtain a 12-lead EKG. You're going to administer 160 to 325 milligrams of aspirin if there's no contraindication. They usually do test that. You would administer 0.4 milligrams of nitro for pain relief. Again, typo right there. Caution if there's right ventricular AMI. Caution if known use of sexual enhancement. Remember Mona B, okay? Morphine, oxygen, nitroglycerin, aspirin, and beta blockers. Even though beta blockers usually isn't on the ACLS, but it's a good acronym to know. You administer oxygen, morphine, and again, the adopted door to balloon time is 90 minutes. That was on the test. Stroke, you're going to use the Cincinnati Stroke Scale assessment. The Cincinnati pre-hospital stroke scale is signs of the facial droop. You want to have the patient smile for you, have them show their teeth or smile. Normal is that both sides of the face move equally. Abnormal is that one side of the face does not move, as well as the other side. You want to do the arm drift test. The patient closes their eyes and they extend both arms straight out with the palms up for 10 seconds. A normal finding is that both arms move the same or both arms do not move at all. Abnormal is that one arm does not move or one arm drifts downward compared with the other. Abnormal speech. Does the patient have abnormal speech? So, for example, to have them say, you can't teach an old dog new tricks. And if the patient can speak correctly with no slurring, that's normal. Abnormal is if the patient's like, you can't see, they're slurring their words or they're unable to speak. Interpretation is that if any one of these three signs is present, any one of these three signs is abnormal, the probability of a stroke is 72%. The presence of all three findings indicates that the probability of a stroke is greater than 85%. So if you are an EMT, you want to alert the receiving hospital as soon as possible so that they're ready for the patient. So before you even get to the hospital, tell them we have a possible stroke victim here. You want to, of course, perform a non-contrast, this is important, non-contrast head CT, because you need to determine is it ischemic or is it hemorrhagic with 25 minutes arrival at ED. And if they are negative for a hemorrhagic stroke, they're going to start the fibrinolytic therapy. Some team dynamics is open loop communication. They sometimes will throw 1 or 2 questions on this slide about open loop communication is used to ask questions during the resuscitation. Closed loop communication is used to confirm repeat orders. Team leaders are important because they can correct or remedy errors, and they are kind of the conductor of the orchestra, right? During a medical emergency, it's almost like an orchestra. Everybody's playing their individual role or instrument, if we're going to go with the orchestra analogy. So everybody needs to be doing their role correctly, appropriately, and you have the conductor that kind of is leading the whole situation. Tasks should be directed based on scope of practice, and team members who cannot perform a task should make the team leader aware and request an alternate task role. If you don't know how to do something, it's okay, say it. And the medical emergency team or rapid response team should be used as a resource if the patient condition is worsening, not just as a means for assistance during cardiac arrest. Yay, we made it all the way to the end. For a free copy of this PowerPoint, send a screenshot that you subscribed to my channel, that you liked it, that you turned on the notification bells to nursingwithprofessorb@gmail.com. Thank you so much for watching. Best of luck.